Thank you for him. We thank Allergan for organizing for us the best speaker in the area, Dr. Bishir. He will give us nice talk about Ozurdex updates in 2020, what we want to hear from him. Welcome him and his known persons, and thank you very much for coming. And we thanks the delegates to attend and to have, if there's any question, they can add and send here in the apps. Welcome.
Thank you very much. So let me start sharing my slides. Okay. So again, thank you very much. These are my financial disclosure. Good afternoon to everybody. I wish I was with you in Oman, but unfortunately, I have to do this from my clinic. But anyway, welcome to everybody, and I hope you have a very nice conference. Now, when there's no doubt in my mind that 2020 is the year of COVID. So I think the two words that we heard the most in 2020 are COVID, lockdown, and I wanted to change this a bit, at least for this half hour. So when Allergan asked me what I would like to talk about to you for half an hour, I say, why not do a review of the papers published on Ozurdex in 2020? So if you go on PubMed and you write Ozurdex and in the title, and then select 2020, the full year, up to now, there are 25 new papers published. Multiple case reports, dislocation or repositioning of an Ozurdex. So those are not very interesting to us. So I selected 6 very nice studies, and I want to walk you through them. So just interrupt me at any time through our moderator if there's any question. Now, the first paper is a paper published in the European Journal of Ophthalmology. The title is Results of Ozurdex in DME, diabetic macular edema patients, early versus late switch. So it's basically, they talk about this paper as a real life, because it's a retrospective study, multi-center, and it was done in Spain, in 3 Spanish hospitals. So how did it work? Well, patients who had DME, either non-treated, so naive, or unresponsive to 3 anti-VEGF were enrolled. What was the definition of unresponsive? Well, it was defined as a best corrected visual acuity that didn't improve with 3 anti-VEGF, or a central retinal thickness that improved less than 20%, or an actual worsening or recurrence of the edema. So these patients with DME were enrolled and received 1 or more Ozurdex and were followed for 12 months. Now, the study population was 129 eyes. The baseline central retinal thickness mean was 439 microns, and we have 3 groups. We have naive patients, 21 patients who didn't receive any injection before and were selected because of new DME. Well, you see, the best corrected visual acuity is 0.2. It's Snellen, so it's 2 out of 10, basically. So very low. And the central retinal thickness is 483. Early switch. What was the definition of early switch patients? Those patients that were treated previously with 3 anti-VEGF, no more than 3. So they were shifted to Ozurdex after 3 injections. 32 patients in this group, a best corrected visual acuity of 0.3 at baseline, and 434 microns of central retinal thickness. And the third group was the late switch. So patients who had received more than 3 anti-VEGF, the mean was 8.6 anti-VEGF. Now here we have 76 patients that after 8.6 anti-VEGF mean were switched to Ozurdex. Best corrected visual acuity and OCT central retinal thickness are more or less comparable to the other groups. So let's look at the results. First of all, the best corrected visual acuity. Now, here in this graph, you can see that there are 2 lines. One, the whiter line is for naive patients, and the black line is for previously treated patients, the early and the late switch. And you can see they are quite comparable in terms of best corrected visual acuity. There was an improvement in all patients. When we look at central retinal thickness at 12 months, there is a higher decrease in the central retinal thickness in the group of naive patients. And I will show you the numbers. So if we look here, the naive patients had a mean change of 288, which was slightly more significant compared to patients who had received previous anti-VEGF injections. So there was no statistical significance, but the numbers are higher in this case. Now, this table is quite important. This table compares patients, the early switch and the late switch. So patients who had received 3 injections of anti-VEGF before going to Ozurdex, and patients who had received more than 3 injections before going to Ozurdex. Now, this difference is super important. So if a patient who were switched earlier, they had an increase in central retinal thickness much higher compared to patients who were switched at a later stage. This was not mirrored in the OCT. So basically, patients who had received 3 or more anti-VEGF injections and were switched to Ozurdex, they changed more or less the same with Ozurdex. But this is very important. So what is the take-home message from this first paper? Well, they suggest that if you have a patient with DME, and after 3 injections of anti-VEGF, the patient is not responding as you would like in terms of visual acuity or in terms of retinal thickness, then it's better to switch the patient to Ozurdex earlier, so after 3 instead of waiting too long, because the patient gets more visual acuity back. Let's move on to a second study. This study was published in International Ophthalmology, and it's basically comparing in patients with diabetic macular edema, it's comparing anti-VEGF versus Ozurdex. It's a prospective randomized comparative study, and it enrolled 48 eyes, phakic, very important. So there was no fear of using Ozurdex in phakic patients, where central retinal thickness was over 250. Patients were divided into 2 groups. Group A, they received either bevacizumab or ranibizumab, followed by PRN injection every 4 weeks. So the patient every 4 weeks received an OCT, and if there was fluid and central retinal thickness over 250, they were injected again with anti-VEGF. Second group, Ozurdex implant, followed by Ozurdex every 3 months if there was a recurrence with the same cutoff of central retinal thickness. And the follow-up was 6 months, which it's not too long, but it's enough. These are the results. You can see in terms of visual acuity, there was an improvement in both eyes, in both groups, sorry. Group A, the anti-VEGF group from 2060 to 2030, and in the group B, the Ozurdex group from 2080 to 2030. And you see they're very comparable. They change slightly in terms of central retinal thickness. In both groups, you get a big improvement in the central retinal thickness, and only at this time point, there is a slight difference in the significance of the 2 groups. But this is the real difference. In group A, the anti-VEGF patients, they received a mean of 4 injections, while in group B, at 3 and 6 months, the mean was 1.1 injection, because Ozurdex, we know that it takes less injection to work. So, of course, we expect the IOP to change slightly more with Ozurdex, and it's reflected at 2 months, a higher IOP, but it never goes over 25, and all patients were managed if there was an increase with topical medication. So the take-home message of this one is that anti-VEGF and Ozurdex are very comparable in terms of best corrected visual acuity and central retinal thickness reduction in diabetic macular edema, but with Ozurdex, you have the advantage of fewer injections. This, I think, is the most important one in terms of DME. It's actually a very difficult study to understand. It's a multi-center retrospective cohort in 25 European centers from 8 countries and Israeli centers as well. Patients with DME who had a central retinal thickness over 300 microns, and I prefer this cutoff instead of 250 because it reflects what I do in my clinic, and had no treatment for the previous 6 months. So no treatment. We can consider them more or less naive patients. And patients had a minimum of 2 Ozurdex, of course, 3 months apart, because you need to wait at least 3 months to repeat the injection. The method. The patients were either analyzed by series. It basically means that all data were pulled together and analyzed, or by injection, which means that this analysis included all best corrected and central retinal thickness data at each study of each patient in the 6 months after the injection. There were 3 comparisons made, very important, between the subgroups. One was the comparison between the previous treatment status, comparing patients who were completely naive with patients who had got some injections the 6 months before. Then duration of DME was compared. Are patients with early DME, so less than 6 months, responding better maybe compared to patients with late DME? And finally, the measure of diabetic control. I always tell my patient to control their HbA1c, to have it under 7 actually. So they use the cutoff of 8, and they try to see if patients who were more controlled got better compared to patients who were less controlled. And these are the primary outcome. Well, the primary outcome is 15 letters of gain, secondary outcomes 10 letter, or an improvement in central retinal thickness. Now, 340 eyes were enrolled. 119 were naive, so no previous injections at all. 221 were previously treated. Overall, after an injection of Ozurdex, there was a significant greater percentage of gain of 15 letters if the patient was naive to treatment, compared to eyes that were treated before with other injections. And while the mean central retinal thickness did not change, and that's exactly what I told you in the other studies, it reflects. So naive patients, they get more letters, but the decrease in the central retinal thickness is the same. Now, these are the results, naive versus treated. Now, let's look at the graph on your left. This is the change in baseline visual acuity. You can see this blue line is the naive patients, and you can see there's a higher, significant increase in the number of letters if patients were naive and received an Ozurdex compared with patients who were treated before. This, as I told you before, this is not reflected by the OCT changes because you see the two lines are quite comparable here. They either naive or previously treated patient improved in this study. What about the duration of DME? 6 months or less or more. Now, patients, blue line, patients with the early DME, they improved in best corrected visual acuity in a significant manner compared to patients who had a chronic DME. But again, this was not reflected in the OCT. The OCT with the Ozurdex improved in both groups. And finally, the diabetes control. Patients in the blue line who had the diabetes with an HbA1c under 8, they improved slightly more, even if there's no statistical significance, they improved more compared to patients in the dotted line who had an HbA1c over 8. And if we go to the central macroretinal thickness, here you see there is not really a difference. You can actually see that patients in the blue line who were controlled, they improved slightly more, but it's not significant. So what's the take-home message? The study overall showed that with one Ozurdex, 1/4 of injections in the per injection analysis and 1/5 of injection in the injection series resulted in improvement of 15 letters. So Ozurdex works to improve best corrected. Looking at the treatment effect over time, the study demonstrated that there was a seesaw, a pendular effect of improvement and deterioration in visual acuity and anatomical outcome. There's a more rapid anatomical improvement in the per injection analysis that was sustained until a maximum effect of the 3 months. And the improved in ATDRS letters is more in naive eyes. So that's, again, a confirmation of what we saw before. Now, let's leave behind the DME and let's move to central retinal vein occlusion. In this study published in the British Journal, this is a multi-center retrospective cohort. 27 NHS hospitals in the UK. They compared anti-VEGF and Ozurdex in patients with CRVO who didn't get any previous treatment. So quite straightforward as a study. And they overall, this is probably a chart review. They reviewed 4,698 eyes. The most of them, they had previous anti-VEGF, as you can see in group 1. And in group 2, the Ozurdex, 605 received Ozurdex. Best corrected visual acuity at baseline is comparable in both groups. Now, if we look at group 1, at 12 months, the best corrected increased to 57.9 letters in 24%. And there is a constant increase, even if it's not statistical significance. Once the patient improves at 12 months, the improvement is sustained at 18 and 36 months. In the Ozurdex group, you get the most improvement after 12 months, and then it gets a little less on 18 and 36 months. Now, as far as the treatment burden, of course, there were more treatment and more visits if patients with central retinal vein occlusion were treated with anti-VEGF, because with Ozurdex, there was only a mean of 1.28 treatments in the first 6 months. At 36 months, the mean number of visits increased with Ozurdex. Anti-VEGF was still associated with more treatments and visits. So at 36 months, 7.06 treatment for anti-VEGF and 1.81 with Ozurdex. These are the graphs that represent what I just told you. But the take-home message is that this is actually the biggest CRVO study comparing anti-VEGF and Ozurdex. And the gains in visual acuity were greater and more sustained with anti-VEGF compared with Ozurdex. And while Ozurdex is actually giving you the advantage of a lesser number of treatment and visit. As far as endophthalmitis rate, they were low in both groups, but slightly more significant in the Ozurdex group. This is another study on retinal vein occlusion published on Grefe, and it's by the Italian group of San Raffaele in Milan. Now, this is prospective interventional case series. Patients who had retinal vein occlusion and refractory CME were enrolled. So it's looking at patients who got 5 prior Eylea and 1 prior Ozurdex. So this is the refractory for them. Patients who got 5 aflibercept injection, then 1 Ozurdex and didn't respond, they were enrolled and they received on the same session 1 Eylea and 1 Ozurdex. And here are the results. Well, 30 eyes were enrolled, a majority of females. 24 eyes were pseudophakic and 6 were phakic. 19 eyes presented with branch retinal vein occlusion, 11 presented with central retinal vein occlusion. The mean duration of the retinal vein occlusion before this combination treatment was 25 months. Baseline central retinal thickness went from 578 to 324 at 1 month, 416 at 3 months, and 352 at 12 months. So a good improvement by combining aflibercept and Ozurdex. And the baseline best corrected visual acuity again improved from, this is logMAR, so 0.73 to 0.61, and finally 0.76. But as you see, the P here is not significant. And if I can point your attention, we're talking about chronic CME in retinal vein occlusion. So it makes sense to me that this vision is not improving a lot because this patient that had long-standing CME. So the results, 6 eyes, only 6 eyes, only 20% of these treated eyes had macular edema recurrence at 1 month after getting 1 Eylea and 1 Ozurdex on the same session. At 3 months, 13 eyes, so 40% presented the recurrence. They received a second combined treatment of Eylea and Ozurdex, and this was actually effective in reducing the central macular thickness. In these 13 eyes with recurrence, there was an improvement from 439 at 2 months to 307 at 3 months. And the best corrected visual acuity assessed in the same range of 0.7. Now, the take-home message here is that the combination of an intravitreal treatment with the anti-VEGF and Ozurdex can be considered when the macular edema in retinal vein occlusion is not responding or is recurring. Because it makes sense, after all, you're treating the VEGF component of retinal vein occlusion and the inflammatory component. Now, we looked at DME, we looked at retinal vein occlusion, but we do know that Ozurdex gives its steroid, so it gives a rise in the IOP. So I'm presenting you this final paper. It's a paper published in Eye that looks at the rate of intraocular pressure increase after Ozurdex. Now, it's descriptive, observational, retrospective, and it's multi-geographic. So it's basically a chart review done in South Asia, done in Europe and Asia, in the USA, and South America. Patients with at least 1 injection of Ozurdex from the 6 years of 2011 to 2017 were enrolled. And the IOP was measured with tonometry, with applanation tonometry at 1 week, 1 month, 2 months, 3 months, 4 months, and 6 months. Now, the results are pretty amazing if you're new to using Ozurdex, because we are always worried, and these results should actually ease our minds. 294 Ozurdex were implanted, mostly for DME, some from retinal vein occlusion, and minor percentage for uveitis. Well, the increase of an IOP after Ozurdex over 25 were 0% in the white, 8% in the Latino, and 9.5% in the South Asian group. The IOP rise of at least 10 more millimeter of mercury over the baseline were 0% in the white, 12% slightly more in the Latino, and 10% so the same in South Asian. And what's amazing is that a spike of IOP over 35 was 0% in the Caucasian, 3% only in Latino, and 2% in South Asian. And only 1 patient out of 294 required filtering surgery. This actually reflects my experience. I've had patients who got 25, 26 after Ozurdex, 2 weeks, 1 month, and they were very well treated with Kozop. I have to say I've never seen, since I've beginning using Ozurdex, I never had to take a patient to surgery with my glaucoma colleagues. These are the results that I just told you. And you can see here the spike over 20. You can see it's more pronounced in Latino and South Asian. So the take-home message for this is that a rise in the pressure with Ozurdex is very rare and very well controllable with topical treatment. Now, before we end, I urge you all, so this is not 2020, so I didn't bring this paper, but this is a paper on ophthalmology retina published in November of last year that looks in phakic eyes with new naive DME. It looks at the use of Ozurdex, and the results are amazing because the second fear that we have is cataract, because we know it's cataractogenic. So the results are amazing. Patients here received a mean of 1.3, I think, Ozurdex. Rescue treatment with anti-VEGF was never performed, and there was no progression of the cataract. Now, with this, I've given you everything I could find about Ozurdex published in 2020. So I thank you for your attention. And if there's any question or some discussion, I'm more than happy to talk to you.
Thank you, Dr. Bishi. Thank you very much. Any questions, please, from the audience? I have one question I want to ask about your experience and what being published from Middle East. As Middle East, the biggest problem we have in Oman, for example, and neighbor country, steroid responder patients. How do you evaluate this? How could you talk about this?
So if you're asking me for publications and data, there are none. But my experience from going from Italy to the US and from the US to here, I didn't see any difference. So I have patients receiving Ozurdex here weekly. I mean, not the same patient weekly, but weekly I do Ozurdex. And very rarely I have to use IOP medications. And I've never had to take a patient to surgery. So I think we should, patients can really benefit from this treatment. So we shouldn't be afraid of glaucoma, and we shouldn't be afraid of cataract. Then, of course, if a patient is already glaucomatous, I think twice. But, you know, it's not always the type.
And those glaucoma, if any develop glaucoma, do you think with medication lifelong they should go on, or this only for short time?
No. So what I do is I see the patient at 1 or 2 weeks, and then after 1 month, and I measure the pressure. So if at 1 or 2 weeks the pressure is high, I put the patient on, usually I use COSOP just because I'm not a glaucoma doctor, I give COSOP to everyone. And I see the patient at 1 month, and if the pressure is back to normal, then I stop the COSOP, and I follow the patient again and see what's happening.
Also a question, there's always argument about exact how many months work Ozurdex exactly in our eyes. Yeah. Because some people saying 4 months, 5 months, and some people saying only maximum 3 months. So from your personal experience, what did you see exactly that in the eyes?
So my personal experience is that after 3 to 4 months, you start seeing a recurrence, if there is any. So that's when you want to see the patient back. So with Ozurdex, you can see the patient less, not every month, but after the 3rd or 4th month, you should see the patient back. That's my experience. I've had a couple of patients that went 6 months or even had to take a couple and they were okay. But usually 3 to 4 months, I want to see the patient back.
It's better.
Yeah.
Okay. Any question from the audience? This was very nice lecture.
Thank you.
I see no questions. I think great lecture.
Thank you very much.
And we hope all the good. Thank you very much. We thank Dr. Bishi for his nice, clear talk. That's why not many questions. And Ozurdex, I feel that a strong gun now in the market. Yeah. And especially in Middle East, not only for uveitis and things like this, but the DME, I think we have DME bigger problem than Western world.
Yeah, absolutely.
Yeah. Thank you very much. Thank you for your
Thank you very much. I wish you a good meeting.